This is our panel discussion. The way it's going to work this morning is we're going to let these guys do a few minutes just introduction to themselves, but then we're going to throw the floor open and sort of consider different thoughts and ideas and needs and questions about the role of technology in delivering service. And that will, so you can start putting your thinking hats on about sort of questions that you might have. We put a bit of thought to this session because those of you that get to go to conferences and forums, the whole conversation about telehealth for me is getting a bit tired, because for me, I've just come back from what felt like a month in Cairns from the National Rural Health Alliance, and Wonka and David's here, and thank you for joining us, David. We'll see you shortly. But again, you go to these conferences, and at a national level, there's talk about telehealth's coming and telehealth's big, and we're going to have to buy in. Well, personally, at my level, I'm a bit fed up with all that. I've been working on it for 4 or 5 years and been pretty busy with it, and where things are happening and it's working and we're trialling and we're testing and we're improving, and all the time and we're having fun with it as well. And to keep going to national forums and hearing the same old stuff about we can do it and it should be done and all this, we're a bit tired of that. So we thought today what we'd do is dive a bit deep. And because of the fact that we've got people in the room who actually are getting their hands dirty in community and delivering services, that we wouldn't do the big high story and the big high pitch. We're actually going to talk a bit about the reality of delivering services with the use of technology. I've got a personal, a bit of a beef about the word telehealth. Julia will remember all this from our time together working, but really I think telehealth's a term that just sort of gets thrown out there now. And it means so much for so many people, and depending on what part of the system you work in, everyone uses the word telehealth, but it means so many different things to different people. So really the purpose of today is talk about the use of technology or technology-driven service, what works, what we're learning, how to do it, and just jump in basically. So if I may introduce to you our panellists today. So I'll start with Professor Branko Seller, who is here today with a couple of hats on, but you're the Research Director at Uni New South Wales and Telemedcare, and also was the former Chief Scientist at the CSIRO, a very esteemed man. We're very privileged to have you here today, so thank you for sharing your time with us. Julia Martinovich, who comes today as the Telehealth Manager from the Agency for Clinical Innovation for New South Wales Health. Thank you to you, Julia. And just a bit of background, Julia and I used to work together at the Royal Far West in Manly, and Julia is a speech pathologist by trade and has making progression now through health management. And Mike Edwards, as I said, one of our our outreach program managers, who's actively and heavily involved and very interested personally in the role of technology in health. So thank you to each of you. I might throw, Branko, I might set you first. I'm going to sort of put a time limit of a few minutes on each of you, just so we get the most of the session. But if you wouldn't mind just giving us a little bit of background about yourself, the work that you've done and things that you're seeing in terms of the delivery of healthcare with technology.
Well, thank you very much. It's a lot of fun to be here, and thank you for the invitation. I've actually been working in this area since about 1998. In about 2000, we decided that chronic disease management was really the big game in town, because we were spending about 70% of the healthcare spend on chronic disease management, its exacerbation. And so I moved my whole laboratory to researching and developing technologies and services for the home primarily. So my work has been primarily chronic disease management in the home, but I've also moved into a lot more now community health centres and supporting rural and remote health workers with proper technology to enhance their diagnostic capability, to enhance their knowledge base so that they can actually reduce flyouts and improve healthcare locally. Most recently, I ran the CSIRO National Telehealth Trial, and that was very successful, and developed a 200-page report that showed something like a 75% reduction in the rate of hospitalisation for people that were being telemonitored at home for the chronic condition, and about a 50% reduction in the use of healthcare services for COPD, CHF, diabetes, and allied and comorbidities. So my particular view of life is that I'm very data-centric. Doctors and clinicians and emergency departments use data to make diagnoses and to make decisions. We found in the CSIRO trial that video conferencing was neither here nor there when it came to telemonitoring the home. Clearly, video conferencing has an important role when you're trying to connect specialists and GPs together. But the unfortunate fact is that in Australia, about 90% of all funding in so-called telehealth is actually focused towards video conferencing between different services. And the alternative form of telehealth, which is really supporting rural and remote communities with diagnostic technologies to do their work, really doesn't get much of a buy-in. So the company that was set up out of UNSW called Telemedcare now does most of its work overseas. We're doing work in rural and remote communities in India, in villages. We're doing work in Miami. We're doing work in China and Colombia, but very, very little here. However, I do work with Richard Cranswick, who's a cardiologist, and we are really fine-tuning some of the technologies that he wants to be able to identify people with badly managed, poorly managed hypertension, which I can tell you is really rife. We've been monitoring people for decades, and I get so sick of seeing people with blood pressures of 180 and 110 remaining on 180 to 110 for years on end. So there's a real issue there. He's also interested in looking at AF. So we have technologies that are very simple, like a simple communication hub in the home that connects through 3G and collects data from spirometers, glucometers, blood pressure devices, ECG devices. Individuals can take their own single lead ECG very, very easily. Individuals can take their peak flows very, very easily. And so all this data, particularly if you have it on a longitudinal basis, if you track it over time, means that you won't have patients turning up at your doorstep so sick all you can do is to send them to hospital. In other words, we identify the exacerbations well before they become acute, and we ensure that the services are in place to stop that exacerbation becoming acute. It's very simple. This is effectively what ED people do by monitoring people in their beds. We simply monitor people at home over weeks. And what we can find out is 2 or 3 weeks before they become acute, we can find that their peak flow has dropped, their pulse oximetry shows a reduction, their heart rate's gone up, their respiratory rate's gone up, and all these are danger signs. So we do this sort of work routinely, and it's extremely effective and quite low cost nowadays. And of course, in the bush, it is very hard to deliver video conferencing. But you can collect data quite easily in the bush from virtually anywhere because the 3G voice network also provides data. If the data doesn't go away now, it will go during the night when suddenly your 3G service gives you 32 megabits, whilst at 10 o'clock in the morning gives you 64 kilobits. So you really can't do a lot of video conferencing type stuff out in the bush, but you can do a lot with data. And so that's been my background.
Thank you,
Is that
Branko.
enough?
Thank you. Well done. Thank you. So we'll come back to Branko with some questions, but Julia, what about yourself?
All right, so as Richard mentioned, I'm a speech pathologist by background, and as I was thinking of what was I going to prepare for this speech last night, I was thinking about my journey with telehealth. About 4.5 years ago, I started working with this man on the right here, and he had an idea to improve the way that we delivered services at the NGO that I worked with. So I'm a paediatric speech pathologist. Kids from the bush used to come and see us for 1 week, get all their allied health services and paediatric services in 1 week and then go away for 6 months. And what we were finding was obviously the outcomes weren't as sustained as well as we would like. So he had an idea that we would use telehealth. When he first mentioned it to us, I thought he was a bit crazy, I would admit. I was very reluctant to do it, but thankfully I had very good support within the organisation to give it a go. I couldn't have asked for a better first session ever as a speech pathologist. I had a well-behaved kid, everything went to plan, and I was hooked. And so a lot of my passion has been getting clinicians to come along with the journey, and 4.5 years ago, a lot of clinicians thought that this was a crazy idea, as if you could sit behind and do video conferencing to provide regular follow-up to our patients. Now we're at a tipping point. Now where I work at the ACI, I work with the clinical networks and clinicians, helping them get on board and making telehealth a whole lot easier. Because I'm in a tipping point now where I've got clinicians that are really interested and willing to do telehealth, but just wouldn't know where to start. So a lot of my role at ACI is going out and helping that set up services. And about last year as well, ACI also chaired the inaugural and the first New South Wales Telehealth Strategic Advisory Group, and that was a result out of a recent review in telehealth services in New South Wales, which can be found on the New South Wales Health website. If you just search telehealth, you can see the review and the New South Wales Health response. And basically the review found that the uptake and maturity of telehealth across the state in all forms, video conferencing and remote monitoring, is patchy, with some areas doing a lot better than others. And one of the reasons for it was that through the consultation they found was lack of strategic guidance and governance. So ACI put its hand up to chair this group and bringing together all parts of the system, making sure that there's an equal mix of metro and rural representatives, and really looking at how we can make telehealth easier, because as you know, easier for clinicians to adopt and embed into practice. Because as you know, it is changing the ways that we deliver care, and there's some medico-legal and some funding restrictions, as Branko mentioned earlier, that are not keeping up with the times. So I guess the aim of the group is to make it easier for everyone to adopt and to share the local telehealth innovations better across the state. Because I know when got told that we had to do telehealth, I wanted to know who else was doing it and how I could learn, and I found it very, very difficult to find. So we've also set up a telehealth capability interest group, which is a broad community of practice that anyone who's interested in telehealth can join. So we've got representation from service managers, CEs of local health districts, to clinicians on the ground and consumers. And really people are sharing their great work that they're doing in telehealth. And I think that's the thing, we just got on and doing it, and we're informing the system through our lessons learning of implementation, what needs to change. So I'm in a very fortunate position now. Thank you.
Well done, Julia. Thank you.
Hi, my name is Mike. I am the Outreach Program, and I'm standing in for Leonie Parker, who was going to be here today. Unfortunately, her plane got delayed last night and she couldn't make it this morning. Ironically, I did ask if we could video conference in at this facility for the telehealth session, and we couldn't. Problem number one. Anyway, I'd like to acknowledge Leonie and Mick Campion, who's the gynaecologist supporting the service. That's a service that's a nurse-led practitioner service out at Orange AMS. And it's important because it's a change in model. It's nurse-led, and it's a colposcopy service. It has been developed over 2 years, and it was initially thought of as a telehealth technology service. It has taken that time to develop the model without even discussing the technology. We've got it set up now where that's where the next phase is, but these things do take time. My background is I'm an analytic programmer, actually. I'm computer buff, and I made a change in career about 6 years ago and came across to RDN, and they took a punt on me, having no health experience whatsoever. And I think of things as a system, or as in a system kind of way, but I also really focus on the needs of the person or the people who are requiring a solution. And that drives every type of solution we put forward. Outreach has been around for a long time. Outreach has been around in the same sort of format in the way that we can fund the delivery of a service. It was built on a visiting health professional flying out and delivering a service. But service delivery has moved on over that time. And one day I hope to envision that when we're creating a budget for a service, we just have it there as telehealth being acknowledged as being part of that. Not how do we look at whether the person can fly there or whether we can support it through various other methods. That aside, been involved in a few deliveries of solutions for telehealth in outreach over a number of years. And I'd just like to share one with you, because I was in a meeting yesterday with a very, very large telecommunications company, and they were talking about the virtual coordination section of delivering technology. Now, being a technology person, straight away I thought virtual coordination, what that means is a human being in the middle trying to connect two technologies together. That might be faxing something. So technology still has a way to go to deliver end-to-end solutions. And video conferencing, yes, we've talked about that. There is a lot more involved in the types of solutions that you can put forward. One example, having a yarn with an Aboriginal health practitioner delivering an endocrinology service that is a video conferencing system, and ensuring that patients would accept the service and be part of the service. And he said the way they got past that problem was to smoke the room before the patients come in. That is the best technical solution I have ever seen for delivering a telehealth video conferencing service. But that was driven out of their need and their ownership of that service. We support, or we want to support, and as part of that today, I'm hoping we can invite people to discuss where they could see technology going, but just think about technology in a very, very broad context. So that's all I wanted to say, so thank you.
All right, Mike, thank you. Now, before I throw open to questions, I'm just going to put David Budd on notice. A question's coming your way. So, David, the CEO of the National Rural Health Alliance down here, and thank you again for joining us today. Shortly, I'm going to throw to you, David, just to give your reflections of the conversations about technology that came out of Cairns recently at the National Rural Health Conference up there. So, just to give you some notice of that. Just, if you can, for each of you, the one or two critical ingredients that people in the room should be going home thinking about if the conversation starts about technology. So what are the two or three things in your experiences, both very different, all three very different fields and backgrounds, but what are the two or three critical things people should be thinking about in terms of technology and health service when they go home?
Well, one of the things that really strikes me is that at the Rural Health Conference, I actually presented a talk and I compared what we do here to Alaska and, for example, Canada. And whilst all of you are doing a tremendous job individually, what we don't have here is large networks that support each other, that have access to expertise in different locations that's always on tap and always available. Because remember, this business of coordinating a practitioner with a patient is actually quite complex. You need to have something set up all the time where you can make sure you have access to diagnostic assistance, clinical assistance, etc. So that's something that I think we should look at as a country, because we don't do that here. If you look at Alaska, as I said, and even India nowadays, they're much better organised in terms of networks. The other thing is that this technology question, the technology ought to disappear. You're delivering a service, it ought to be really simple to use, intuitive, and if you don't use it for a month, you come back to it, you can use it again. So all this business about, oh, how do I do that and what do I do here and what button do I push, that has to all disappear. That's from the user's viewpoint. From the patient's viewpoint, the key thing is from the first time I did a clinical trial, I was always told the patients can't do it, won't do it, will never do it. They have always done it with 90% plus compliance. The problem with this is not the patient, it's actually the systems, the clinicians, the workers that really stop them doing what they can do. And that has happened since 2001, 90% plus compliance, but we're never going to do it. So they're just...
Thank you, Branko. Great. Julia?
I don't know what much more I can add other than echoing a lot of what Branko said. I would agree that the patients, you would be surprised, the patients are very compliant. It's all about the ease of use as well, making it easier and getting clinicians on board. The other thing I would do, if you're very fortunate to be in a position where you're not wedded to a certain type of technology, is really map out what you want to do, who you want to provide it to, and make sure the technology meets the model the best it can rather than the other way around. Because sometimes clinicians are told they have to use this technology and walk to the other side of the room in the hospital or a different location, and people just don't want to do it. So really get an understanding of, you know, what you really want out of it before, if you're fortunate enough, then letting the technologist prescribe something to you, because they're great. I really like technologists, but at the end of the day, if you want clinicians to use it, you've got to own it.
I would suggest technology should be the last part of the conversation. I'd also suggest, like I said before, local ownership and driving that local ownership for any solution. I'd also suggest don't talk about them being pilots. We always talk about telehealth being a pilot. We've got to start making it more of a topic around it being the delivery method.
Well, they call it more pilots than Qantas in telehealth. David, what about yourself? What's your reflections and thoughts on a conversation about telehealth?
Yeah, thanks, Richard. Look, I think the panel's touched on pretty well a lot of the things that were reflected at the National Rural Health Conference in Cairns, and we had, about 1,200 people there. A lot of discussion, I suppose, that hasn't been touched on so much. I think Branko did a bit that it's all very well to have wearable devices and remote monitoring and all sorts of other ways of actually, having your monitoring, your results sent. But if you haven't got good communication systems, then, what the heck? So there were very strong focus on access to good broadband. Sorry, I'll let that fall. Thank you, Phil. Very strong focus on things like access to broadband and getting guarantees that, in fact, you will get the speed and the uploads and so forth that you need. And, I think we need to face the facts that the NBN is going to give, everyone better access than we do now, although I think there's a lot of things about satellite access and so forth which still need to be worked through. I think one of the interesting things that and again, it's been touched upon, is that it's sort of like we're saying, well, we're here to enable these things to happen, and we're going to enable consumers to get access to this, but the consumers are already doing it. I mean, they're ahead of the game. They're out there. I know people who are using systems that are based in the UK or the US to do things about monitoring their conditions, and a bit like Branko, selling products overseas, not using them in Australia. So consumers are not asking for permission, they're not waiting, they actually just want to be enabled to do it. So it's about the system actually catching up with where consumer mindset and consumer capacity is already at.
Great. Thank you, David. Cheers. All right, some time for some questions. Thank you.
Oh, hi, I'm Rowena Ivers. I'm a GP in Illawarra, and we did have used Telehealth. We're lucky enough to have enough bulk billing specialists locally to not need to use it that much, but we still lack access to some of the remoter, especially the surgical kind of specialties. One of the issues is that there's been uptake, obviously great uptake in AMSs, pretty good uptake in some of the, especially new specialists, but the biggest issue is that hospitals and when you talk to specialists, the VMOs or staff specialists in hospitals, they're not using it and they don't have capacity, and this is friends who are specialists felt like they had no control over the IT in hospital, and they just seemed to think it was unmanageable. So the situation is you then have our patients go to the big tertiary hospitals, public hospitals, because that's the ones they can afford, but they can't then go and have follow-up visits by telehealth. And they spend all day, we're only coming from Illawarra, so it's not very far, but, they might go in for a 10-minute consult, post-surgical consult, and it's been a huge drama to get them there. Whereas by telehealth, it could be very easy, but it seems to be very slow and laborious through the New South Wales health system. That would also apply to their uptake of electronic referrals. It's basically unheard of in the hospital system. They've just started to send out electronic discharge summaries and electronic letters, but just there seems to be a block when it comes to sending anything electronically, and you have to mail them. Sometimes some of the clinics, the patients have to physically take the referral to the hospital. They won't even accept it by fax. I'm just wondering if there's any moves to work with New South Wales Health to get the department moving.
Hopefully through this Telehealth Strategic Advisory Group, it's still very much in its infancy, but that's one of our things, is to work on the other systems to make it easier. And I think I touched on before that some of the medico-legal things around telehealth, or that should make telehealth easier. There's some medico-legal restrictions that New South Wales have in place that prevents it. So one of the big things is electronic referrals is something. So we would work as an advocacy and lobbying group to make that reform. That's our mindset. So watch this space, hopefully.
Thank you.
I just want to make a point that hospitals have actually doubled, the cost of hospitals doubled in 10 years. The cost of primary care has stayed on CPI. So what's really interesting is that there has been this huge increase in the proportion of money that goes to hospital, but they haven't really stayed up with the times. And if you, again, look at our hospitals in Canada and Alaska work, every one of them basically supports a network. So there's a network that connects to a regional hospital, and that regional hospital has got a permanent setup for doing telehealth consultations, telemedicine, review of diagnostic data, referrals back and forth by remote area health workers, and that's done routinely. But you're quite right, the hospitals here don't do that very much.
My comment on that is doing a recent analysis of even 3 definitions on telehealth between World Health Organisation, ACI, and New South Wales Health, you could see the complete difference in what they thought it was there to achieve. And the definition from New South Wales Health was around that transaction of a video or a communication mechanism, much more so than what the World Health Organization was about improving access. Saying that, I've seen a lot of infrastructure being built within hospitals, and that infrastructure not necessarily being used or being made redundant within a year because new technology comes out. I heard yesterday some commentary around where a patient was offered a video or a phone as a follow-up type of service. 95% chose the phone. They're in their own home. They may feel that they thought the phone was sufficient. Now, that might not be suitable for every follow-up, but just think simply, we should look at those simple solutions first and then start to look at the more, high-level video conferencing or other solutions like that. So,
Thank you. James?
Thanks, Richard. I got a few things to say that, and I'm sure there'll be a question in there somewhere. And I'd like to remind everybody that Peter Yellerlees, the Professor of Psychiatry at Queensland University, was using digital consults in 1996, had to leave the country and go to the States because he wasn't recognised in his own country, and is now a world leader in telepsychiatry. So we are a little technophobic in this country, particularly when you look at things like teleconsults and other things such as, solar power. There are a number of, and I just reinforce what Branko said, that there are a number of organisations such as my own where we're using the digital space for paediatric psychiatry in the Murrumbidgee region with Royal Far West. We're using the digital space for psychological consults through an organisation in Melbourne. We've got 500 consults per year so far in that area in our region, and we're also doing iPad through Skype for Business with between GPs and aged care facilities in our footprint, and we're now about to expand that into the ambulance service, who are obviously big providers in aged care facilities. So there are small organisations like my own that have a relatively large footprint that are in this space, but it's kind of half-assed and it's not coordinated at any systemic level. And I hear what you're saying, Branko, and I do apologise for not ringing you back last week. But mea culpa. How do you see? I hear what you're saying about the networks, but how do you see them developing, and how do you see them being held together?
I think one of the issues that we've had in New South Wales particularly is that there's been this devolution model, which in many respects is great. It's supposed to give the periphery all sorts of hands-on control of what they do, but it also meant that whatever capability there was became dissipated to zero. And I have people from different local health districts calling me up and saying, I'm the new telehealth services coordinator. What's it all about and can you help me? And I say, well, it's not really my job to help you. Is there no other capability that can actually provide you that sort of expertise? So there's very little, there's been a walking away from coordination from government. And it's part of this sort of idea of public-private partnerships, of privatising things. The fact is there has to be leadership. When you look at the real needs of rural and remote communities, whether in Alaska or India, the drivers have been from know-how at government and then devolving to service, but not devolving to know-how. And then ultimately you devolve into the know-how once the service is established. But if you just say, let 1,000 flowers bloom, all you end up getting is weeds, quite often. They may well bloom, but you do need to have a cohesive, coordinated group of people that knows what they're doing, working with government, getting the resources together, creating networks, and then making those networks work. Not over 1 year or 2 years. The Ontario Telemedicine Network took 12 years to fully establish, and now it's massive, same as in other places. So we need to get leadership, we need to get funding, we need to get long-term funding, and we need to also tap on what the rest of the world is doing, because we are really ethnocentric and quite arrogant about what we think we do. I mean, I was in a hospital in Korea recently, and really it was better than anything I could find in Australia, but we only think that it's the Anglo-Saxon world that we follow. There's a lot to be learned by looking at overseas experiences and adopting them here, but doing so not over 1 year, but over 2, 3, 4, 5 years, and funding it properly.
Thank you. Any other questions?
I'm just from an NGO in Western Queensland where we contract out specialist providers. We have one solely telehealth clinic that occurs, and we have 2 other providers who do an alternate face-to-face telehealth. I wondered if there's research done into show whether there's improved outcomes for a combined method, or if outcomes are just as good for a solely telehealth service. Anyone?
Well, I can respond to that to some measure. I mean, obviously, if you're talking about chronic disease management, there's a care team involved, and that care team often involves primarily the patient, his or her support services, the community nurse, the GP. That's really the nucleus of it. And then, of course, occasionally there's a specialist. So that care team is paramount and really important. But what we demonstrated was that you can deliver tremendous results by empowering the patient to do more at home before they become acute. Of course, the whole process of support then, of education, also happens through what we call a care coordinator. So we have a care coordinator model where a single care coordinator looks after 100 chronically ill patients, reviews the data and orchestrates the responses. So it's a form of care coordination but based on data. Not based on complicated paperwork and hundreds of people wandering around. It's based on, oh, that patient is doing fine, they're stable, we can let them be for a bit. That patient is showing early signs that worry me, I need to do something about that. And this person, if I don't do something with this person because all of his signs are showing red, they'll be in hospital in a week's time. So you can risk stratify patients through the care coordination process. But of course the care coordinator doesn't deliver care, they coordinate care. So they're going to depend on you and you and you and the AMSs and the GPs to deliver normal care. So that's the way it works. The problem in Australia is that we also have fee-for-service, and that really has been, from international experience, a killer of innovation. And I can give you an example of that in Miami, America, which is probably the worst health system in the world, through the Accountable Care Organisation now has changed dramatically, and things are happening there that aren't happening here.
I can add on to your question from an allied health perspective, particularly in physio, OT and speech pathology. Most of the research that has been done at the moment has just looked at sole telehealth and compared it to face-to-face, and what it's coming out is it's pretty much on par. It's the same outcomes, which is good. It's not better than, it's not worse than, it's just equal to, which is really reassuring. And I think for me as a clinician, it proved to me that telehealth is a safe and legitimate modality and we should just be getting on and doing it.
And Professor Mark Dadds, who's just gone to Sydney Uni, he's also got similar studies around face-to-face versus telehealth for child behavioural issues as well. So that Mark Dadds is worth looking up for that.
And thanks. We'd welcome that kind of research within outreach with any of our programs. We have so many disciplines, so many different providers, so many locations that it is a very good area to do that type of thing.
I've got something to say there. You just made me remind me of something that I'm working with our pain network. So the pain network, management network at ACI deals with our multidisciplinary pain clinics across New South Wales. And as of last year, we started providing an outreach and supplemented it with some telehealth programs to 3 LHDs, Southern, Far West and Murrumbidgee, that don't have access to a pain clinic. And we're comparing the EPOC, which is the pain outcomes measurements that the pain clinics take, from face-to-face to that outreach model. So watch this space, we could have something interesting.
The other thing I want to say is measuring the outcomes is really quite complicated. The CSIRO trial spent $5.4 million trying to get a document that could be used definitively as a working document. And we did cost-benefit analysis of telehealth, telemedicine at home, telemonitoring. What we found out was that basically about $2,500 investment per patient saved about $19,000 in terms of reduced hospitalisation, reduced MBS, reduced PBS, and that's available in a 200-page report that the CSIRO put out. So there are increasing cost-benefit analyses that are coming out. Of course, telehealth is complicated. There's so many different definitions of it. You know, video conferencing is telehealth. The patient-provider model is the classical Medicare model, which is why they're comfortable to pay that, but they will never fund a at-home telemonitoring because it's not the classical patient-provider model. And that makes life really, really difficult within the funding model we have in Australia. So there is evidence, and interesting enough, there was one study that showed the worst outcomes were based when the only measurements were video conferencing. It actually increased costs. So there was a study done some time back.
Thanks. Last question, I think.
Just looking at the financial part of it, this is still a service provision and someone got to pay for it. And currently this is through the Medicare system, and correct me if I got it wrong, but in the Medicare payment system, the payment is stuck to a location of the specialist. Whereas with the telehealth, you can be very flexible. I could be even driving, I could be at home. And how do you work through the system, make it more flexible?
And also to note, there's the location restrictions, but it's only really covering consultants to provide the consult. It doesn't include allied health, as we would be, Rich and I would be very much aware of, or GPs. Interestingly, something came up, I did it yesterday. As you would be aware, the MBS task force review is happening at the moment, and they are reviewing certain items, but I just emailed them again for the 50th time and said, what about telehealth? And I got quite a positive response, and they said they're looking at all item numbers. Can you please resubmit what you're saying about telehealth? So I would encourage people to lobby on that as well and explain some of those issues. From a New South Wales health perspective, we did put in a submission where we did say that the location items should be removed, because I deal with the spinal cord injury network, where travelling, even they could live in Randwick and travelling to Prince of Wales is a huge old deal for them, and telehealth is really well done, but also looking at broadening it from video conferencing to remote monitoring as well.
Just maybe one little point. I actually ran a workshop with senior people from government about 2 years ago, and we were trying to find what were the impediments to funding telehealth. And what came up very strongly was the idea that the classical model here is the patient-provider model, and we're really nervous about funding anything else. As if somehow or other that alternative was going to be, and they were worried about exploiting or having it exploited, as many other things have been. We pointed out that in our trial, we knew to the microsecond exactly who was online, when, talking to whom, about what. So, it is completely auditable. But the anxiety about the Medicare budget going out of control is something that drives governments to being really, really cautious. But I also pointed out that the current Medicare system, based on the provider-patient model, can be exploited mercilessly and has been, and I have many examples of it. So we have to overcome these anxieties because, and fundamentally, you have to look at how the funding model works.
From an outreach perspective, I guess we have some flexibility to fund beyond Medicare for telehealth. One of the big areas I think where funding may be let down is in that coordination component. But we also think broader, and again, I go back to looking at the innovation type thing. So if we can fund a Medicare, fund a ENT perhaps to do the telehealth. But let's even go further than that. Let's look at how we could possibly fund the Aboriginal health worker and train that Aboriginal health worker to screen and then identify the patients that should be seen by the ENT and look at ways of making those efficiencies there. Outreach gives you an opportunity to look at that type of innovation as well.
Oh, David, sorry.
Sorry, I just have one question. I just wonder whether there's been any research done around the cultural appropriateness of telehealth. And I mean, I know in my AMS, people prefer to see clinicians face-to-face rather than any other model. So I'm just wondering if there has been anything done about that and whether it is culturally appropriate for Aboriginal and Torres Strait Islander people.
There have not been any major studies, although that sort of stuff has been done in Alaska, where you have a lot of First Nations people. There's been a huge number of studies there, which you may want to read, and also in Canada, same reason, First Peoples. But most of the networks there are first controlled by the First Nations. They're actually controlled by the AMSs, and they're funded to deliver that service in a culturally appropriate sort of way. From a personal experience, I've tried for years to develop telehealth in rural and remote areas. I was in Warburton to Kimberley for 2 years, and a lot of the problems are communications. There's some shameful examples where Broadband cable is outside the health clinic at Warburton, never used because they had to be charged $15,000 per month, and they do $2.4 million worth of flyouts. So, there's all these anomalies, and they have to be overcome with the way the system works. I don't think the cultural appropriateness is a problem. We're doing a small project with Bulamuji Aboriginal Medical Service, in which we did find out, for example, that shoving a tablet in an Aboriginal community with lots of kids around is sort of disastrous. They'll tear it to pieces. They're interested, they love it, they fiddle with it, they want to do things with it. So we don't use tablets. We use a home hub, collects the data. It looks pretty boring, nobody fiddles with it. So there are simple things like that we've learned, but not in terms of a large cultural awareness type program.
Actually, we did an evaluation at AMS when we were doing telehealth and interviewed some of our clients. And actually, for some of them, they were people who probably would never make it a specialist because they don't like going to the hospital. But being there at the AMS with the Aboriginal health worker, it was all positive, really. And I think it seemed to be, I guess, on par with going to see the specialist. But I think there are advantages in terms of having transport to come to somewhere very familiar, being with people that they really trusted. And actually, for us as the GPs and other stuff, it meant we never had interaction with the specialist. We could kind of duck in and have a bit of a word to them as well. So it was very acceptable.
And we did an evaluation about 5 years ago when the MBS item was first introduced, and there was a very particular focus on Aboriginal and aged patients as well. So I can show you that, and the results were very positive.
Okay, so thank you, Mike. So we're going to stop, but before I finish, I'd like to do something just to say thank you to all. I think you're staying for lunch, so we'll bail you up a bit more there. Now, Branko, I should be saying thank you to you very much, but I'm actually going to finish by giving you a bit of a story about Julia, because for me, she epitomises the opportunities that come for young people in our workplace, but also you've got to take them and grab them and go with it. So the example she gave at the start of the session about when we started, she's not the first person to call me crazy and may not be the last, but I won't forget that. But we put an offer to the clinicians at our NGO and said we need to give it a go. We need to create a different way of working, a different way of thinking to support better care in country areas. Out of 80 clinicians in that NGO, there was only one person that put their hand up to give it a go, and it was a young lady who said that she would, but she didn't do it in the room. She had to wait until the next day to come and whisper to me that she was prepared to give it a go, and it took a half an hour conversation to get her over the line to actually do it. You used the word support, so that was very critical. We planned it very well. We would move very fast because we had to go fast, and people often get worried about moving fast means reduction of quality. Well, it's not the case. It's actually the thing you've got to do is plan it through and think through and create time and space. So I was really pleased to hear you talk about the support. But one of the critical things to celebrate here is that trial wasn't done with 2 kids, it wasn't done with 4 kids. The very first telehealth pilot in speech pathology serviced 153 children in 18 different communities across rural New South Wales, and it was Julia who did each of those. And I sit here with great pride seeing her today now moving on from full-time practice into health management and health administration, and to see you take the steps you've done is absolutely fantastic, and I'm thrilled for you to be here in front of everybody today, so congrats to you.